This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2016, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Controversies in Mechanical Ventilation, Low Tidal Volume Strategies. Jonathan Brady Scott is a registered respiratory therapist, adult critical care specialist, and fellow of the AARC. He is an assistant professor and the director of clinical education for the respiratory therapy program at Rush University in Chicago, Illinois. Mr. Scott discloses that he is a key opinion leader for Aerogen and is an advisory board member for Sanovian Pharmaceuticals. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis.
Hi, my name is Brady Scott. I'm an assistant professor of respiratory care at Rush University in Chicago. Here to speak to you about controversies in mechanical ventilation and the concept of using low tidal volumes for everyone. So general objectives here, I'm actually going to take you through a timeline, perhaps where positive pressure or mechanical ventilation even started, and how we progressed through times all the way up to now. So that evolution will be described, and we'll review some of the current literature that supports how things are currently evolving. So Galen was a noted Greek physician that actually was a scientist that lived in the 2nd century. And he taught that breathing was required for circulation. So there was a concept that the physical act of breathing actually caused the heart to beat, which is an interesting concept. But it's funny, this idea actually held for around 1,500 years. This is probably due to the Dark Ages and not a lot of scientific creation during that time. But it's interesting that it was believed for a long time that breathing was actually the reason the heart would beat. So we fast forward through quite a bit of time, and into the mid-16th century, we had Vesalius, who was a professor of anatomy, and who was often considered the founder of modern human anatomy. Kind of had a contradiction and wasn't really sure this was the case. So in 1543, he published a book that's actually, we would call that now On the Fabric of the Human Body. And he published a book and had a lot to do with anatomy and physiology and respiration, and really this is probably the first time we had any reference at all to positive pressure ventilation. Again, you're talking now in 1543, perhaps the first concept, positive pressure ventilation was discussed. And so in this book he quotes, but that life may be restored to the animal, an opening must be attempted in the trunk of the trachea, into which a tube of reed should be put. You will then blow into this so that the lung may rise again and take air. So many, many, many years ago, we'd start talking about positive pressure ventilation. Fast forward on through time. So in 1667, Robert Hooke, a scientist who performed some more experiments using Galen's hypothesis, used an animal model, which was a dog, to help understand basically how blowing air through an animal really affected it. And what he found was that by using this model, he used bellows to generate a constant flow of gas through the lungs. And by doing this, air was entering the airway and exiting through chest wall holes in the pleura. And the dog lived, although it was a constant flow and not a breath moving back and forth as we know it now. It was interesting that he noticed that when the blast of air through the dog stopped, then the dog would begin to convulse. But the dog would soon be revived again, he says, by renewing the fullness of his lungs. So this was further research into what we know as mechanical ventilation or respiration in general. And I really liked what Hook said at the end here. He says, "I shall shortly make some experiments, which I hope will thoroughly discover the genuine use of respiration, and afterwards consider what benefit this may be to mankind." And if you think about where we're at today in mechanical ventilation, how such a hot topic is, and how it impacts our patients every day inside of a hospital, and how it's revolutionized healthcare, think of how he was thinking of how will this impact our patients in the future, and what a profound impact it actually has. Fast forward again, so I'm kind of going pretty quick through your timeline, but in 1774, we know that Priestley and Schill discovered oxygen, and so Lavoisier also discovered the importance of oxygen in respiration. Ironically, though, this might have hindered the development of resuscitation techniques, largely because the mouth-to-mouth, which had already been described in the literature, was kind of halted because it was discovered, or it was thought that exhaled gas into a patient was deplete of oxygen, and it was of no purpose, had served no greater good. So this probably actually, this discovery of oxygen and what it was, and how patients may be breathing in and out, actually changed perhaps something that was beneficial to patients at the time. Again, very quick fast forward again. I'm going to go now into the late 19th century all the way to the 1950s. Then we get into the concept that it's a little more common in our terminology nowadays, I think, of negative pressure ventilation. And so we know that this is negative pressure using subatmospheric pressures delivered around a body. So this is in several different versions, and some of these were just like in this photo here in the top right, where we had these large rooms of iron lungs, and you got to have a big, huge iron lung for one patient, and obviously you can see that this is an inconvenience for all parties involved, our patients and the caregivers. But nonetheless, it was saving people's lives for various disease process. And now if we move from this 1950s era into the present, we think about the concept of positive pressure ventilation, and it's probably a little more common in our everyday conversation, as I said. The polio epidemic was really a major moment of change for mechanical ventilation. And at first, positive pressure was really thought of as a ventilatory support mechanism, so more of the bulk gas flow back and forth, air in and air out. But then slowly and over time, there was a focus began to transition towards more the oxygenation failure part of mechanical ventilation because of technological advances that were a lot of them that were associated with the analysis of blood gases. I do want to step back just for a moment and talk about that in 1774. So when we think about positive pressure nowadays, we instantly think of injury that is caused by positive pressure. But look, I just want to go back here just for a moment. I know that we're already in the 1950s and beyond, but in 1774, John Fothergill first described lung injury from positive pressure as a concept. And he quotes, "It's been suggested to me by some that a pair of bellows might possibly be applied with more advantage in these cases." So, and I guess as a clinician, I personally never used bellows for positive pressure, but I think of this kind of as one of our resuscitation bags, perhaps. And he's talking about when he's comparing this to the blast of a man's breath, which is like mouth-to-mouth, versus using bellows. And he just ends here with as great a force as those of another man can exert, which by the bellows cannot be determined, meaning that we don't really know how much pressure we're exerting on the patient and what that may be doing to the patient. And again, that's all the way back in 1774. So he in his mind was thinking, maybe it's not so good to give somebody a lot of pressure inside of their lungs. So think about that. That was over 250 years ago that this concept was described. And also in 1829, it was demonstrated that bellows could cause pneumothoraces. And it's interesting that it was thought that pulseless patients, those without a pulse, just simply couldn't tolerate positive pressure ventilation. I think that we know now that this perhaps is a wrong interpretation, that it's not that the fact that the patient's pulseless, they couldn't handle the pressure, it's perhaps the pressure was too much or the volume was too large. And also, this was another moment in history that this was perhaps a setback. So this is again a lung injury because actually in 1837, the use of bellows and mouth-to-mouth resuscitation was no longer recommended by the Royal Humane Society because of perhaps this negative consequence of using positive pressure. And so here we are again thinking about once, positive pressure being described not only as something that's helpful, but also perhaps it's hurtful. So you can see how things have changed over time. Moving back in terms of still continuing to talk about lung injury here in the 1940s, the mechanisms that led to pneumothoraces and barotrauma actually were discovered at that point. In the 1960s, there was a major focus on oxygen toxicity, and it was observed that low tidal volumes and low PEEP were associated with atelectasis and hypoxemia, and I don't think that really, I don't think there's a lot of debate on that even today. And because of the fear of high FiO2 levels, larger tidal volumes were utilized because really we gave the patient larger tidal volumes and we had less hypoxemia as a result. This was actually even supported some in some of the papers that were actually published in the New England Journal of Medicine in 1963. This was a major study that was demonstrated that higher tidal volumes during anesthesia resulted in less acidosis and improved oxygenation, which is clearly very important measures inside of a hospital and obviously in the OR. And this paper was thought to be the major paper that popularized the concept of atelectasis in mechanically ventilated patients. So the question is, so here we are in the 1960s and positive lung injury had been described in 1774, had been looked at again, and the thought, the idea that positive pressure, perhaps large tidal volumes could be dangerous was there. But so really was there no indication, even despite the fact that atelectasis was less that was discovered in operating room patients, was there really no indication that large tidal volumes were dangerous even at that time? I think maybe there probably actually was. So in 1974, it was demonstrated that high distending pressures lead to pulmonary edema. And this was measured in an animal model. And if you look at the graphic that's on the right here, you'll see 3 lungs. And so the left lung there was a peak inspiratory pressure of 14 centimeters of water. The middle lung was ventilated at 45 centimeters of water and a PEEP of 10. And the right lung was ventilated at 45 centimeters of water and a PEEP of 0. And you can see clearly just on the right there that the lung is injured from this kind of pressure swing. There was also an abstract that was published around in 1975 that described patients in ARDS that developed barotrauma after high levels of PEEP and tidal volumes of actually 22 milliliters per kilogram. So that's, thinking about it in today's time, 22 mLs per kilogram of predicted body weight is quite high. Fast forwarding again, a little more closer to today. In 1997, biotrauma was identified as the consequence biologically associated with mechanical ventilations. You can see that people were starting to think that perhaps the injury could or can be or was occurring, and more research was being performed at the time. It was shown that injury occurred in 2 ways, and this is still believed today largely that really it's the collapse of the lung unit, which is atelectasis, or it's the overdistension of the lung unit from high volumes. So in this actually, and coupled with the fact that the patient has an underlying disease process that causes perhaps an increase in alveolar permeability, could lead to the invasion of all of these inflammatory mediators, bacteria, and endotoxins into the circulation. In reality, this influx is what really probably leads to end organ damage and multi-system organ failure. And we step back for a second and we take a look at it. This is probably explains why a lot of our ARDS patients actually die from multi-organ failure rather than dying from hypoxemia. So it's these mediators, these endotoxins, and everything in the circulation. So it's not just lung disease alone in ARDS that's causing our mortality in our patients. So if we look at our graph here, it's just a simple graph that kind of shows that You look on the left there, you can see when we have inadequate tidal volume, the consequences of inadequate tidal volume are atelectasis, hypoxemia, hypercapnia, and inflammation. And on the right, we have this idea of alveoli that are opening and closing all the way back to near collapse and opening back up and near collapse. And so this is also causing injury to the alveolus. That's, that really the consequence at the end of the day is a ventilation perfusion mismatching, alveolar capillary injury, inflammation, hypertension, and this concept of barrel trauma in the lung. And so in this graph here, you see that this is something that you see a lot in the literature, but it really shows where injury occurs. You have these zones of overdistension when the breath is too big, and you have these zones of lung de-recruitment, and both of these zones are where injury occurs inside the lung. I always say it's the Goldilocks mentality here that we have to keep the lungs just right. It has to be in the middle. The lungs need to be open but not overdistended. The volumes have to be enough to keep the lungs from collapsing or overextending. So this is, here on this graph you can see we're kind of in a safe zone. So we have a smaller zone to work in reality, moving back and forth. And so now we start to think about, using larger tidal volumes, and maybe there's some injury, but the data wasn't strong, and data was developing, and there were some people that were touting perhaps we got some injury. And so now if you think we've had a pendulum swing towards not just making the blood gas okay, but doing so while at the same time thinking about injury that could be occurring to the lung. So in thinking about it, before lung injury was really understood, the goal of mechanical ventilation was really to correct acid-base abnormalities. And in reality, it was to do it as quickly as you could. So put the patient on a ventilator, normalize the blood gas. And if the pressures were high, then that was a consequence. And so that was, this leads to this would lead us to early intubation because we wanted to correct the acid-base balance. More ventilation and more pressure. More is better mentality. And now we think this more mentality is resulting in more injury. And thus the pendulum swings a real effort to minimize the side effects of mechanical ventilation. Nobody was debating, or we've never really debated, that patients need mechanical ventilation. They need positive pressure. They need negative pressure. Whatever it is, they need to breathe, right? Patients need to breathe. We figured this out a long time ago. But we've switched to think that perhaps there are side effects to this. This is not always safe. And so we can keep the patient alive while at the same time not causing more injury. So efforts took many shapes over time. So there was a lot of different development over time. So we've had non-invasive ventilation. So we've actually made a lot of steps forward in not intubating people at all. Now this is still positive pressure, but it's still without an endotracheal tube. And some of sometimes the sequela events that happens from being intubated. So we've taken many steps to even just keep people off the ventilator in the first place, which, of course reduces the amount of sedation that we have to give patients and all these things. We've learned about reducing the concept of auto-PEEP, and how auto-PEEP was occurring that was increasing pressures inside the lungs. We've learned about permissive hypercapnia with kind of being okay with the pH being a bit low, the CO2 being a bit high, if I can not injure the lungs. And in 2000, I think is a really big moment in lung protection when the ARGNet trials demonstrated that there was a significant decrease in mortality from 40% to 31% by delivering smaller tidal volumes to ARDS patients. And this was an incredible study because in reality, and one of the ways I like to talk with colleagues is we learned how to save more lives by turning the knob to the left. We turned the knob down. And so we turned the volumes down, which was maybe making our oxygenation not as good, and it kind of went against the grain of what we were used to doing. But we turned it back to the left, we dialed it down a little bit, and we saved more lives by doing so. And then so if you're not familiar with this landmark study, this was in 2000. This was the ARDS network. And what they looked at is they compared basically two groups of ARDS patients. One group got volume assist control at 12 mLs per kilogram, and the other one got 6 mLs per kilogram. And again, to just reinforce what we basically, death before discharge home and breathing without assistance, the group receiving the lower tidal volume was 31% versus 40% in the high tidal volume group, which was a significant value, and that was a huge find in treating those ARDS patients. So again, turn the volumes down alone was saving lives. In more literature reports, as we keep moving through this, in 2004, there was a study that was a retrospective cohort study that focused on patients that were being mechanically ventilated for greater than 48 hours, so a couple days on a ventilator. But what was interesting in this study, and the reason I wanted to bring this one out, was this was in 2004, but this was on patients that didn't meet acute lung injury criteria. So this is not necessarily your ARDS patient, your PF ratio criteria that we're looking at. So the findings of this study, and this was a while back, 25% of patients without acute lung injury in the beginning that were ventilated for greater than 48 hours, they developed lung injury. So that's a lot, 25%. It was thought that mechanical ventilation with large tidal volumes was a risk factor for acute lung injury. And actually, when gender and height are ignored, women are more at risk for the lung injury, according to this study. So the conclusion by the authors here was that we should give strong consideration to limiting large tidal volumes, not only in patients with established lung injury, but also in patients at risk for acute lung injury. So that's in 2004, this right after the ARDSnet. So we knew what it was. We knew the data in the ARDS group. Now we're kind of looking at folks without established lung injury. So this is another major find as we move forward. And then there were several others. So in 2012, we had a meta-analysis that looked at the association between using lung protective ventilation with lower tidal volumes and clinical outcomes among patients without acute respiratory distress syndrome, and this was in JAMA in 2012. The objective of this study was to determine whether the use of low tidal volumes is associated with improved outcomes of patients receiving ventilation who do not have ARDS, and that's really who I'm talking about today. I'm not talking about the ARDS patients. I'm talking about now really focusing now from here on out those patients who do not have ARDS. So this paper, and the JAMA paper, included 20 articles and 2,800, a little over 2,800 participants, which is a good number. And so when you look at the analysis, the meta-analysis using a fixed effects model in looking at lung injury, everything favored low tidal volumes. When you look at mortality rates, everything favored using lower tidal volumes. When you looked at pulmonary infection, this too favored using lower tidal volumes. So the conclusion of this meta-analysis, the authors concluded that among patients without lung injury, protective ventilation with the use of lower tidal volumes at the onset of mechanical ventilation may be associated with better clinical outcomes. So this was now we're starting to think maybe just from the beginning we should go ahead and just go straight into lung protective strategies, and this is be better associated. They state that more research is needed to evaluate high versus low tidal volumes in a heterogeneous group of patients receiving mechanical ventilation for a longer period of time. So they admitted that more data is needed to better understand everything that's going on. And I think that's a common theme. We get some research, and every time we get some bit of data, then we have more questions. So I think it was wise of those authors to say, perhaps we need to investigate even further. Moving on, in 2013, we have another paper, a review article that was looking at prophylactic protective ventilation. So the question was lower tidal volumes for all critically ill patients. And I like this because this described this concept of multiple hit theory. And so, meaning that the lung is primed by the initial insult of disease, pneumonia, sepsis, trauma. So the lung is primed and ready to go to be injured, if you will. And the disease process itself, coupled with large tidal volumes, lead to high alveolar pressures and high transpulmonary pressures. This may amplify pulmonary and systemic inflammatory responses, leading to ventilator-induced lung injury and iatrogenic ARDS. So it's kind of this, not just the volumes and not just the disease, perhaps both of them together is why we are beginning to see this. And so we have, this concept of, this graphic shows a concept of direct pulmonary insult, indirect pulmonary insult, and then you have the insult secondary to mechanical ventilation, and at the end of the day, we have ventilatory induced lung injury. So this paper was nice in the way that it approached, so when do we do this? So thinking about it, so mechanical ventilation settings are noted to often be unchanged after initial intubation. The patient is intubated, we set some settings, and we kind of walk away from it for a while, and we do other things. Maybe we're taking patients on transports, we're going to CT, we're going to MRI, or wherever we have to go, but there's not, maybe, in some cases, there's not so much focus on what the pressures are, the volumes are, what could be potentially happening to the lungs. But it is noted and known now that lung damage can happen only after just a few hours of being on mechanical ventilation. So if we intubate somebody, then that logic means that we suggest that perhaps it is better for us to begin right out initially with being lung protective. And they also talk about how ARDS is often unrecognized or delayed by many clinicians. So the authors of this paper recommend that we implement lung protective ventilation at initial intubation as soon as we get there. So the question is, how do we do that? So first we focus on tidal volume. So how do we protect the lungs? Well, we protect the lungs by regulating how much air we're actually putting in the patient. And so they suggest, and they talk about here, in patients without ARDS, but at risk, in what we're talking about, tidal volumes between 6 to 8 mLs per kilogram of predicted body weight can be used safely. Patients without risk factors can be ventilated at less than 10 mLs per kilogram based on the available data in their paper. We got to make sure that we're using predicted body weight and not actual body weight, as we know that predicted body weight is calculated by gender and height and not actually how much somebody weighs. And that's very important because there can be a wide variation of that based on actual body weight. PEEP and FiO2 settings. If you're thinking about prophylactic protective ventilation, to be quite honest with you, according to this paper and even maybe today, optimal PEEP is still unknown, and we're trying to better understand that. It's thought that zero PEEP should not be used and is associated with worse outcomes, so this concept of putting somebody on zero PEEP is probably not good. And the authors of this paper actually recommend starting at 8 centimeters of water. And so think about that. So, to be honest, we all know that 5 is almost like a baseline PEEP. And here we have authors recommending that perhaps we should start with the 8. So 8's the new 5. But that's probably not that unusual if you think that we're also starting with lower tidal volumes. So we're going to associate lower tidal volumes to prevent overdistension, but at the same time, we have to prevent alveolar collapse by perhaps giving a little more PEEP. So these kind of thoughts are coming along. And moving on to a paper that's here and now in 2015, this paper from Critical Care, lung protective ventilation with low tidal volumes and the occurrence of pulmonary complications in patients without acute respiratory distress syndrome. It's a systematic review and an individual patient data analysis, a new paper. And so what did this paper investigate? Well, they looked at the association between tidal volume size and occurrence of pulmonary complications in patients without ARDS. They looked at the association between the occurrence of pulmonary complications and the duration of stay in the ICU or the hospital. And finally, they looked at the crude and attributable mortality of pulmonary complications. And so when they flip through here, the papers actually goes into a lot where they look closely at pulmonary complications, acute respiratory distress syndrome, pneumonia, and in-hospital mortality. And the summary of the findings really say that the authors report here in 2015 that there's a strong evidence for a protective effect of ventilation with low tidal volumes. Suggestion that there's a dose-response relationship between tidal volume size and the development of pulmonary complication. And development of pulmonary complications were associated with the number of ICU-free days, number of hospital-free days, and increased mortality, which gives us further evidence that suggests that actually the size of the breath that we're giving the patient has a huge impact on the care of the patient in the ICU on mechanical ventilation. So now if we stand back and take of everything we just seen here talked about, the question is, what do we know today? One, unfortunately, what we know is large tidal volumes are still common. Despite the evidence that we have, there are still some textbooks, there are still some papers, and still some reports that larger tidal volumes, and I say large tidal volumes, I'm generally considering that, for the sake of this discussion, probably 10 or above 10, still common in today's ICU. We know that pulmonary damage occurs within just a few hours after the initiation of mechanical ventilation. Clinicians, unfortunately, we often miss early or mild ARDS. And you know, that's kind of makes you raise your eyebrows, but all of us that are at the bedside know that we have so many factors to deal with. We have so many moving parts, we have so many patients and so many things that these things that go unrecognized and no true fault of anyone. It's hard to pick these things up earlier, especially when it's subtle. Well, this has been well reported. So the common themes in the literature right now is we should probably initiate low tidal volumes on all patients early. Like, why wait? If we know that lung injury can occur in only a few hours, why would we put somebody on settings that would injure their lungs and then go back and turn it down? Why not just start? Because in reality, it's just simply too late once the ARDS criteria is met. It's already happening. This injury is already occurring. Why don't we try to prevent it from occurring in the first place? Why react and not be proactive in preventing this approach? And we got to be honest with ourselves and realize that only a few hours of mechanical ventilation can cause problems for our patients. And that's kind of hard for us to think about, but it's true, and well, it's thought to be true and has been suggested in the literature. So I want to conclude with some very basic conclusion here. And the fact that we know that low tidal volumes are pretty much considered a standard in ARDS patients. And there's strong evidence that supports this, and I think that after this many years, it's finally very common language that we're using low tidal volume strategies in those patients. And the evidence is mounting. It's mounting that we should be using low tidal volume strategies for all patients in the ICU. And when we do this we're going to, again, I think this is, as clinicians, we're being proactive in preventing lung injury and not reactive to lung injury. And we know that blood gases may not have to be perfect. So we've got to try to balance a blood gas that is working for us with at the same time protecting the patient's lung. And when we do that, it seems that we're doing the right thing in terms of delivering positive pressure for our patients. For a moment, let's put ourselves in a large academic medical center. Let's say that we are going to have a patient come to us from an outside facility. And as we get this patient, the patient is brought to the room. We look at the initial vent settings they are transferred on. And what we find is that the patient is currently set on 10 mLs per kilogram of predicted body weight. And for a tidal volume, a PEEP of 5. They're on 100% oxygen, so an FiO2 of 1.0. And their saturations on a pulse oximeter are 91. Blood gas results show a PaO2 of 65. So this patient is, with a FiO2 of 100 or 1.0 and a PaO2 of 65, we know that that's not so good. And so other numbers that we have on our ventilator, we see that our peak pressures are 40 and our plateau pressures are 32. So we know that our plateau pressure is a little higher than it should be as we try to be below 30 for lung protective mean. So what do we do at that point? We can start to intervene by implementing an ARDS-NET strategy, using kind of an ARDS-NET protocol in order to start lung protective mechanical ventilation. And so initially, we may in this case start at initially decreasing the tidal volume down to 8 mLs per kilogram of predicted body weight. And remember that when we start to decrease the tidal volume, we must be considering the minute ventilation that's involved here. So if we decrease tidal volume, we may have to increase the respiratory rate in order to hold the minute ventilation to assure that ventilation is adequate. So we initiate 8 mLs per kilogram of predicted body weight. And again, so predicted body weight is a calculation that we would calculate a little bit differently for males and females, and this is based on gender and on height. And then once we do that, we will multiply that number either by 6 or 8 or 10 or wherever we're trying to be to try to understand what our actual tidal volume may be. So as we're trying to lower this plateau pressure, and how we lower the plateau pressure is by dropping the tidal volume, we have to understand that our oxygenation is still not so good. So our PEEP is currently 5 and our FiO2 is currently 1.0. So what do we do now? Perhaps we go ahead and we implement 8 centimeters of water of PEEP. And by doing that, we may increase our actual plateau pressure. So plateau pressure initially falls because we have decreased our tidal volume, but because perhaps we've increased our PEEP, our plateau pressure rises again. So how do we lessen this problem, or how do we continue on down the path of lung protective strategies? At this point, based on our calculation, we would also, a little while longer, and you can actually find the RRT-ACCS protocol that's online that helps walk through this, and actually the time frames that in which you do this. But I'm going to give you, we'll talk about a quicker version here, because it's really about the concepts here. So if my plateau pressures are still elevated, my PEEP is higher based on my need for oxygenation, my next move is to go on down to where I want to be, which is at least 6 mLs per kilogram of predicted body weight. Now again, I may be stepping down a little slower based on our protocol through time, but ultimately we're going to try to end up at a tidal volume of at least 6 mLs per kilogram of predicted body weight. So if the 8 of PEEP didn't do the trick to get our FiO2 down a little bit, we would probably have to incrementally turn up the PEEP a little bit more. And we do this, there's a lot of ways to set PEEP, but the RRT-ACCS protocols that are available, like I had mentioned, they offer PEEP and FiO2 tables that help us learn how to titrate PEEP and FiO2 so within a goal range. And I do want to point out that in this ARDS patient, the goal ranges for saturation, your pulse oximetry, it's not 97 to 100, it's not 95 to 100, it's actually much lower than that. The goal range is 88 to 95. With the idea being is we don't need that much oxygen. We're okay with a saturation that's a little bit lower. So it's a trade-off. We're okay with sats that are 92 or 93. We don't have to have the patient on 80%. So we use these PEEP and FiO2 tables to titrate in terms of getting our oxygenation within a goal range. However, we have to consider as we do that, when PEEP changes, then perhaps our lung pressures are changing as well. So let's stop for a moment and say that we have moved our patient down to 6 mLs per kilogram, and our rate is 22, and our PEEP is 10, and our tidal volume, our plateau pressure is 26. And this goes on for a while and it's doing fine, but we notice over time that our oxygenation still hasn't improved, and because it hasn't improved, we want to increase the PEEP. We increase the PEEP, let's say that our plateau pressure now has increased to 31. What's our next move? We have to protect the lung. In this case, using the protocols that I'm referring to, we simply turn the tidal volume down again, maybe to 5 mLs per kilogram in order to keep that number a little bit lower. So the whole point I'm getting to here is we run these protocols that have been out for a long time, and we're all the time adjusting the ventilator to protect the lungs, to keep the pH okay, to keep the PaO2 okay, and to keep the saturations okay. Notice that I didn't say to keep the PEEP perfect. I didn't say to keep the pH perfect or the saturations perfect. But we have these guidelines, and it kind of lets us kind of keep these numbers to be okay. And actually the RRT-ACCS protocol even allows us to go on down to 4 milliliters per kilogram of predicted body weight in order to protect the lungs, to keep those plateau pressures under control. And so while the RRT-ACCS idea and theory of mechanical ventilation is not new, I just wanted to review that for those of you that haven't utilized it that many times. understand how we actually turn the volumes down incrementally. And remember, when you're turning the tidal volumes down, you lose minute ventilation, right? So frequency times tidal volume equals minute ventilation. If we lose one side of that equation, we have to increase the other. So as the tidal volume is going down, remember to you may have to turn up your respiratory rate in order to maintain ventilation and CO2 removal. Otherwise, your pH is going to take a big hit. Turning the volumes down would have a very negative consequence on your pH at that point. Now, that is a kind of a rough way to, obviously a very quick run through of the ARGENET protocol, but really it was just trying to illustrate how we would go about being cognizant of protecting the lungs all the time. As this changes, this may change. As we turn the PEEP up or down, it may have an impact on lung pressures. As we turn tidal volumes up or down, it may have an impact on lung pressures. If we turn the PEEP up or down, it may have an impact on oxygenation. This may impact how we have to run our FiO2. So as we know that mechanical ventilation is quite complicated, and we know that one thing affects the other, so we have to keep all of these main protective ideas in mind. But now we know that it's not just for the ARDS patient. The thought is now we don't just protect those lungs. Maybe we should be protecting all lungs. So now let's back up just a bit and think about our patient again. So perhaps when this person was intubated, instead of starting on 10 or 11 or 12 mLs per kilogram of predicted body weight by just arbitrarily picking a number or picking 10 mLs per kilogram, perhaps we would start at 6 mLs per kilogram. And so that's a big change. That's a large change for us. How do you maintain ventilation? Well, instead of a rate being 12 or 14, perhaps the rate has to be a little higher than that in order to maintain your minute ventilation and CO2 removal and the pH that you're looking for. PEEP and FiO2, as a study that I talked about earlier, they're recommending perhaps using 8 now instead of 5. Is that very solid in the literature? I think we still have some data. We still have some research to do on that. But if it's reasonable to keep the pressures and keep the PEEP and helps us with our oxygenation, perhaps that may be a way that one would consider starting. So, maybe a new way to do this is to start at 6 mLs per kilogram of predicted body weight instead of the 10 mLs per kilogram. Maybe the rate has to be a bit higher. We have to make sure we're adjusting for air trapping and make sure that's not occurring. And so this patient, instead of us seeing these high numbers and reacting to it, they initially start at these lower pressures and lower volumes and protect the lung the whole time. And so in that way, we kind of lessen this multi-hit theory that we're actually not going to, because the patient is sick. If this patient was a septic patient or had pneumonia, the patient is already sick. The last thing they need is the addition of the high vent pressures to cause ventilator-induced lung injury. So again, let's think. Patient is intubated. We initially start with 6 mLs per kilogram of predicted body weight. Respiratory rate to maintain the minute ventilation that we're looking for. PEEP and FiO2 maybe can still ran by PEEP and FiO2 tables. Increment up, incremental changes up, incremental changes down. And so by doing that, we're running almost an ARGENET type protocol on a non-ARDS patient and still keeping these main tenets in mind, and where we're trying to control tidal volume and we're trying to control the plateau pressures that are below 30. And as we do that, obviously we're going to keep up with our blood gases and any changes along the way. And for some, this is a much different kind of strategy. Some folks may choose to start at 8 instead of 6. But I think right now, we know that the idea is we need to begin to protect the lungs right from the beginning. We don't need to wait until the patient has ARDS, until they have a PF ratio that's really bad, before we begin protecting the lungs. It's suggested that perhaps it's too late at that point. So it's just kind of again, a pendulum swing, and we're still swinging over towards protecting all the time. So that's just kind of some rough case studies of how perhaps we would implement this. So moving forward, again, like I just mentioned, what we know is using the large tidal volume is not that uncommon. So I don't think it would be a far-fetched to say that there are still some very large tidal volumes that are being initiated at the point of intubation. And we know that damage occurs in the beginning. And, and we're not great at catching mild ARDS. So we need to jump on this earlier. How exactly we do that, that's still up for debate. I threw some numbers out there. We're not really sure if that's the perfect way to do it, but we are sure that we need to be thinking about lung injury from the beginning. So perhaps we should initiate low tidal volumes earlier. Is it 6 mLs per kilogram? Is it 8? Is it 6 to 8? Whatever you're comfortable with, or how gas exchange is impacted. Why wait? Why wait until ARDS has started? And again, finally, just to repeat, we know that mechanical ventilation causes problems in only a few hours. So even if we start with the higher numbers quickly right after the point of intubation, we need to perhaps move very quick to begin to protect the lungs. And what I want to do is I want to conclude by saying that in kind of thinking back just briefly about our case study, it probably didn't shock you at all to think that with our ARDS patients that we need to protect the lungs by turning the tidal volume down. We need to be looking at the plateau pressures. The plateau pressures need to be below 30. This is not new. This is accepted, very standard practice in today's. What's new is the fact that we might need to be doing this for everybody, even if they don't have lung injury. So the evidence is mounting to support this. And again, I don't want to walk away with saying that we know exactly how this works yet. We have a lot more research that needs to be done. But the research is mounting and it's coming out all the time. And there's a lot of talk about using 6 mLs per kilogram on everyone. And so with that, it's something to think about. It's something to move forward with, and understanding that really mechanical ventilation is not about making the blood gas perfect. It's about doing what we need to do for the patient while not causing more harm. Thank you.